you know.
Good, Vince.
Okay, so good evening, everybody. It's a great pleasure to be back at the Seattle Science Foundation. And tonight we're going to talk about a difficult topic, which is the cervicothoracic kyphosis. And this is going to be led by my partner in crime, Dr. Ali Ozturk, whom we've done lots of these type of deformity together. And is going to lead you with an excellent lecture. And then our two fellows, Mike Spadola and Greg Galanon, will show you some cases afterwards. So the junction of the cervical and thoracic spine, obviously it creates challenges. Sometimes it used to be unrecognized. More and more we recognize it, but we'd like to share our knowledge and the way we treat this type of pathology. So Ali, my partner in crime, thank you on.
Okay, just share my screen here. Sorry, guys, I'm just
the green arrow.
Yeah, I found that. 1 second. Okay, here we go. All right. Okay, sorry about that. Good evening. I'm Ali Ozturk. I'm a neurosurgeon at the University of Pennsylvania. As Dr. Arlay mentioned, we've been teaming up for the last almost 10 years now on some of these more complex deformities. He's been a dear friend and mentor over the years. It's a pleasure to be here at the Seattle Science Foundation. My talk tonight is on the surgical treatment of cervicothoracic kyphosis. I'll mention a few things. I will make several allusions to cervical kyphosis in general, but the majority of the talk will be focused specifically on cervicothoracic kyphosis. And I'll also try to abstain as much as I can from too many arcane formulas or an over-reliance on numbers and focus mostly on principles and techniques instead. The cervicothoracic junction, broadly speaking, refers to C6 to T4. It's a unique area of the spine where the lordotic and mobile cervical spine transitions into the rigid kyphotic spine. This subjects it to opposing mechanical forces. Something to consider about the cervicothoracic junction is anterior or lateral approaches are significantly harder here than most other areas of the spine, and that's something that we have to consider, particularly in deformity. One last consideration is that the particular anatomy at this region can be highly variable also. Cervicothoracic kyphosis is a severely morbid condition. It can lead to a loss of horizontal gaze, making even ambulation difficult. Simple tasks such as personal hygiene, chewing, swallowing can be quite challenging. It can lead to severe and chronic neck pain as well as myelopathy and radiculopathy. The etiology is varied. It can include congenital factors, neoplastic, ankylosing spondylitis, trauma, degenerative changes, and more commonly, we're seeing iatrogenic causes of cervicothoracic kyphosis, particularly post-laminectomy or proximal junctional kyphosis in the setting of a fusion extending into the upper thoracic spine. Small degree of kyphosis after a long segment fusion is almost expected, up to about 10 degrees. Factors that might make this operative include a fracture at the upper instrumented level or the one right above, myeloradiculopathy, a loss of horizontal gaze, progressive and severe pain despite conservative treatment, and progression of the deformity or even instability. There are several measurements unique to the cervical spine. I think many of us are now pretty familiar with lumbar parameters, lumbar lordosis, pelvic incidence. There's a few I'd like to mention. On the left here is the chin brow vertical angle. If a line is drawn tangential to the brow and the chin and measured with a vertical axis, gives us the chin brow vertical angle. Obviously, 90 degrees would be an extreme chin on chest deformity. We like this number to be about 10 degrees or less. Similar to the C7 plumb line, we talk about a C2 plumb line in the cervical spine, which goes from the middle of the C2 vertical body, and we measure that to the posterior aspect of C7, which gives us the cervical SVA. The T1 slope can be considered akin to the either sacral slope or more like the pelvic incidence. Probably in this case, it's quite fixed. And similar to pelvic incidence, a higher T1 slope usually requires a larger amount of cervical lordosis, and the reverse statement is true. And lastly, when we talk about cervical lordosis, we typically measure from the bottom end plate of C2 to the top to the bottom of C7. This is the Ames classification, which I find helpful. It uses a cervical deformity descriptor along with several modifiers. This is sort of comparable to the Schwab classification in the thoracolumbar spine. It describes the deformity as with the apex being in the cervical spine, the cervicothoracic junction, thoracic spine, the craniovertebral junction, or primary coronal deformity, with several modifiers that you can see on the right, including the SVA, the CBVA, the cervical lordosis, or I should say the T1 slope minus the cervical lordosis, which we like to, again, similar to the lumbar lordosis being comparable to the pelvic incidence, we like to be within about 10 degrees of one another, and the presence or absence of myelopathy. When we assess these patients, an extensive preoperative workup is critical. As always, history and physical is key. All patients should get imaging of the neural elements, which includes an MRI of the C and T spine. If MRI is not feasible, a myelogram should be obtained. A CAT scan of the C and T spine is very helpful to assess for bony union, assess for flexibility and rigidity, as well as especially in patients with prior instrumentation and fusions. Standing x-rays, full-length 36-inch minimum x-rays should be obtained on everyone. And something I'd like to really impart tonight is that we shouldn't resist the temptation to kind of look at cervical deformity in isolation to global balance and thoracolumbar deformity. We have a low threshold to obtain DEXA scans, especially in women who are older than 70. Flexion extension x-rays are very helpful to assess for what kind of correction we can get passively. Extensive preoperative clearances, especially cardiology. We like the patients to see our own cardiologists here at Penn, who are a little more attuned to the complexity of these cases, the length and the amount of blood loss. They tend to be a little more thorough, and they obtain regular echoes on everyone. Nutrition consults, we're increasingly realizing how important this is, particularly with the wounds. And even if a patient appears, well nourished and even overweight, consider getting a nutrition consult because it can be deficient. And of course, smoking cessation is critical. The goals of surgery are to restore horizontal gaze, relieve any neurologic compromise, prevent progressive deformity, and hopefully alleviate pain. In terms of operative strategy, as always, we like to assess how mobile or rigid or fixed a deformity is. In the case of mobile deformities, even at the cervicothoracic junction, consideration should be given to preoperative traction, anterior surgery in the form of ACDFs, ideally multiple ACDFs, or corpectomies combined with posterior osteotomies is still very effective, and in many cases safer with a better complication profile. In rigid deformities, just like the lumbar spine, 3-column osteotomy work is necessary. Keeping in mind, again, as I mentioned previously, that anterior access to the upper thoracic area combined with a rigid deformity usually favors a 3-column osteotomy. This is a schematic sort of outlining the bony work. I think most people are sort of familiar with this. It's very similar in the cervical spine as it is to the rest of the spine in a posterior column osteotomy or Smith-Peterson, or many people kind of use Ponte osteotomy. I think posterior column osteotomy is probably the best terminology. The bilateral facets, the inferior portion of the lamina, the ligamentum flavum are removed. In a pedicle subtraction osteotomy, we'll go over this in more detail, of course. The entire posterior portion of the vertebral body, along with the pedicle and a wedge shape of the vertebral body, is removed and subsequently closed. In a vertebral column resection, the entire segment of the spine is removed, usually requiring anterior column reconstruction. The more aggressive we get with our osteotomies and our corrections, the higher the complication rate. This has been proven with many, many studies, and I think many of us who do this sort of thing for a living would agree with it. So as we go from a posterior column osteotomy to PSO and VCR, we get much better corrections, can be achieved, but they usually can come with a higher incidence of complication. This is a paper from the ISSG that I found quite helpful in terms of sort of thinking about different types of cervical deformities. Broadly speaking, they divided in this paper into a flat neck deformity, which is sort of a diffuse loss of lordosis throughout the cervical spine, a focal kyphosis, and the cervicothoracic kyphosis, with the apex being mostly at the cervicothoracic junction, and a primary coronal deformity. I'm going to focus the majority of the remainder of this talk on cervicothoracic variant. Once again, we should always sort of consider anterior surgery combined with posterior facetectomies and osteotomies in conjunction with pre and intraoperative traction as a very good option, and perhaps in many cases should be our go-to option if feasible, if the anatomy is feasible, and if the deformity is mobile. Here's a few diagrams showing grade 1 and grade 2 osteotomies in the cervical spine, which are sort of similar to the lumbar spine or the thoracic spine. This is a patient, just to make this point, patient was referred to me prior C5 to T1 instrumented fusion, both anterior and posterior, who developed progressive kyphosis at the cervicothoracic junction. This patient not only had a mobile deformity, but a very favorable neck anatomy, which enabled anterior access. And we were able to treat him very effectively with preoperative traction, followed by an ACDF at the cervicothoracic junction and posterior extension of his fusion. So this can and should be an option in the appropriate patients. However, with upper thoracic kyphoses that are particularly rigid, where anterior access is difficult, as it frequently is, 3-column osteotomies need to be performed. Our workhorse in this case is the pedicle subtraction osteotomy. I'll detail this a little more in a bit. Traditionally speaking, a lot of the initial papers of a cervicothoracic PSO was described at the C7 or T1 level, although I think it's our preference to perform it at T2. And I'll go over this in a bit also. VCR is similar 3-column work, typically reserved more for a very severe focal kyphosis, a gibbous type deformity, and once again, usually requires anterior column reconstruction. This is a paper from UCSF by Chris Ames comparing perioperative complications following 3-column osteotomies versus only posterior column work. In their paper, they didn't demonstrate a significant difference in complications. However, there was a trend towards a higher complication rate 3-column work, keeping in mind, of course, that this is really in the best of hands and best of centers. And I think many of us would agree that 3-column osteotomies have a higher complication profile. This is also a fairly recent paper in JNS Spine favoring T2 as the preferred level for PSO, and that's been our practice here. It has we feel a lower risk to the cervical nerves that innervate the intrinsic hand muscles, and a much lower risk of vascular injury. So our preferred level to do the PSO is at T2, and typically we'll do a posterior instrumentation from C2 about T6. That's a lot of levels. I should add that many might not be necessary, particularly in younger patients with good bone quality. Although in some of the more elderly patients who might be osteopenic, it's nice to have the two anchors at C2 with good pedicle screws, ideally going all the way down to T6 for additional fixation. In terms of our surgical setup, we use an open Jackson table. Neuromonitoring is an absolute must. Cell saver. Intraoperative imaging of your preference, whether that's fluoroscopy, navigation, O-arm, or Zeem. And we place the patient's head in biplanar traction. I'll illustrate this in a little bit. The alternative to this is, of course, Mayfield skull clamp or halo suspension. This is a picture of our typical setup of biplanar traction. We apply usually 2 Gardner wells to the patient's skull and 10 pounds of weight attached to each of these ropes for both traction and extension. The patient's head in this position is actually completely floating. There'll either a horseshoe headrest or just some ACE wraps are placed under the patient's head. Ideally, the patient's head won't even be contacting the horseshoe headrest, and it's and the only function that serves is really to catch the patient's face if the weights were to fall off or something like that. But it doesn't have any other use besides it. The patient's head is completely placed and suspended with the weights. The advantage we think this gives us is that the patient's head is mobile and can be manipulated sterilely intraoperatively and under in a controlled fashion. Here's an alternative setup with a single Gardner Wells tongs, but the same principles of biplanar traction. You'll notice down here just a rest to catch the patient's head in case the weights were to fall off, but it's not really doing anything except supporting the breathing tube. These cases are uncomfortable cases for the surgeon because of the patient's deformity. The patient's head in this situation would be going straight down many times in a fixed angle. Maximize the reverse Trendelenburg on the OR table as we've done here. And a pearl that we found that's quite helpful is to switch sides with your co-surgeon or your assistant, resident or fellow. It eases some of the pain on the surgeon's back quite a lot. I'm a big believer of comfortable surgeon is a safe surgeon. One other pearl, I'll mention this later also, placing subaxial screws in the subaxial spine or at C2 is very difficult in this position. So what we've preferred to do over the years for a T2 PSO is actually to place T1 pedicle screws for proximal control on the osteotomy, but we place the subaxial screws in the C-spine after closure of the osteotomy, after the patient's head has been brought back. It's actually significantly easier and allows for better placement of our screws. I'll outline here sort of the surgical steps, and I'll use T2 as the level of the PSO. Obviously, if the level's different, some of these levels down low will be different. But for TSO, what we typically do after positioning the patient, exposure, we'll instrument T1 to 6. As I mentioned, we leave the cervical screws till after the osteotomy closure, but the T1 screws gives us access for temporary rod placement and allows us for compression against it if to help us close the osteotomy. After placement, we remove the proximal 6 or 7 centimeters of the rib, keeping in mind 2 articulations between the rib and the vertebral body, one at the transverse process and the other at the pedicle vertebral body junction. It's easiest to make a cut along the rib where it's desired using a drill or even a Misonix. And I find that a Cobb elevator with the concave side facing down lends itself nicely and fits into the space nicely to disarticulate the rib and ideally remove that rib head in a single piece. It's not mandatory that the rib is removed in a single piece, but I think it saves a lot of effort later. Subsequently, the transverse processes are removed. We perform laminectomies from T1 to 3, so one level above and below the level of the PSO. Bilateral facetectomies at the level above and below, completing the posterior column osteotomies at that level are performed. And ideally, at this stage, we should be looking at the apical sac, as well as 4 exiting nerve roots, and we like to see about a whole inch of the nerves as they exit. And we should be staring down the barrels of the pedicles. The pedicles are subsequently respected. A wedge-shaped defect is created in the vertebral body using an eggshell technique. At this stage, temporary rods, it's a good idea to place temporary rods, at least unilaterally. The lateral walls of the vertebral body are removed using a Lexel rongeur or a Japanese rongeur, and the posterior wall is impacted using a standard impaction technique. Cage can be placed, and a typical lumbar T-lift cage kind of works well for this, a banana shaped to serve as a fulcrum. That may or may not be necessary. And at this stage, we can hold the Gardner-Wells tongs in a sterile fashion through the sterile drapes and extend the patient's neck to close the osteotomy. This can be done without any surgeon scrubbing out. And it can be done without that unclamping of the Mayfield, which can sometimes be violent, and the patient's head dropping, which I think can be dangerous at times when there's essentially nothing connecting the head to the rest of the spine, and the spinal cord is completely exposed. The final rod is attached to the contralateral side, and then the ipsilateral side screws are placed. Subaxial screws are placed if you left them to the end, as we typically do. And additional compression can be applied to obtain additional lordosis if necessary. At this stage, it's very common to see some dural buckling, which is usually a good sign indicative that we have corrected deformity. But we want to take a Woodson instrument and really make sure that there's no kinking of the spinal cord itself, and ensure that all 4 nerves that are exiting are patent. These are a few diagrams also demonstrating the extent of the bony resection. As I mentioned, once the posterior elements are removed, we ideally want to be looking at the dura of the spinal cord and 4 exiting nerve roots with a good portion of the nerve roots visualized. These 2 nerves, obviously on either side, will now be sharing one large shared foramen. I'll leave everyone with some pearls. As I mentioned, it's helpful to switch sides, especially since oftentimes you find yourself leaning towards one direction. Placement of the subaxial screws after osteotomy closure is quite helpful. Again, that's just because of the angle. Suspending the head in traction and keeping it mobile rather than fixed in the Mayfield, I think is safer and very expedient during the surgery. Remember to inspect the neural elements after osteotomy closure with a Woodson, and please look at the cervical kyphosis in the setting of the global alignment of the patient, including the lumbar lordosis, which can often be a masquerader, or patients, but particularly ankylosing spondylitis patients, might have problems in both and might need both areas operated on. That's an important conversation to have preoperatively. These are my references. Thank you very much for having me. And with that, we'll have our 2 excellent fellows, Mike Spadola and Greg Callanan, present some cases, and hopefully at the end we'll have some time for questions and discussion.
So maybe what we'll do is we'll take questions once the fellows have started the talk. Okay, so
Sounds good.
And I would just monitor the chat room. If there's any questions, please don't hesitate to ask your question through the chat room, so we can use it as a base of discussion.
Vince, it's Izzy. Great talk. Great topic. One of the things that I found very, very helpful, much like your double suspended Gardner-Wells traction, is the pneumatic headrest that you can clamp onto the Jackson table. And it's got 2 handlebars on it that, very much like what you were describing, manipulating the cervicothoracic junction.
You're talking about the C-flex? Are you talking about the C-flex?
I don't know it called the C-Flex, but it's Mizuho. It's made by the Jackson table people that clamp onto their table. And it's a pneumatic headrest that you clamp the head, but then you can move the whole cervicothoracic junction in a very smooth manner with it. So that's something to just look into if you haven't seen it.
Yeah, well, we use
Called Smart Fix.
Hmm. Hey, Jens, how are you? Good. So why don't we go ahead? Just Michael, what did you get to
Vince,
case?
before you go ahead, Jens actually had a question. He said, how low should we instrument in these deformity osteotomies? So how low in the thoracic do you go?
Ali, you want to answer?
Sure. It depends on the bone quality. I think in young patients, again, assuming the PSO level is T2, probably C4 to T5 is satisfactory, and also, of course, depends on the patient's alignment also. But usually C2 to T6 in some of the more typical elderly 70-year-old osteopenic patient, I think is but it's, I think, open to your judgment and obviously individual circumstances as well.
Okay, so Michael,
the last thing I'll say is a lot of times we're seeing this, most frequently as a result of a fusion that ends in the upper thoracic spine, in which case it's preferable to attach on to the prior hardware, I think, instead of leaving some segments in between.
Michael,
All right.
go ahead.
Thanks, Dr. Ole, Dr. Ozturk. So I'm Mike, and Greg and I are going to share some cases. Our first one is Jo. This is a 37-year-old female who's presenting to us with significant trapezius pain and upper thoracic back pain, complaining of issues with horizontal gaze, no issues with radiculopathy or sensory changes, but does note a decline in her recreational activities due to this pain. Of note, she has a past medical history of idiopathic kyphoscoliosis, which was treated with a T2 to L3 fusion. You can see the scans on the right side. She has approximately a unit rod with sublaminar wires, and then distally a hook construct. On exam, she's full strength, sensations intact, but does display limited neck range of motion, specifically in extension, and then tenderness to palpation over the upper thoracic spine and the trapezius muscles. When you take a closer look at her pre-op standing films above the level of her construct, you see she has proximal junctional kyphosis with a greater than 100-degree thoracic kyphosis curve. 60 degrees of that is at T1 to 4 with a T3-4 apex. She's compensating well overall with her sagittal alignment due to this hyperlordosis in both the cervical and lumbar spine. Her cervical SVA is positive at 5 centimeters. So clearly this is where her issues are stemming from. She got a CT myelogram to assess the neural elements. It shows no significant stenosis. There is anterior cord draping in the upper thoracic spine. And then you can see that from T1 to about T6, there's complete fusion of those bodies from her previous surgery, leaning or making us think that this is going to be a fixed deformity. So sort of going down that road of treatment options. And you can see on her scout film for that CT that angle of the thoracic kyphosis doesn't change. So again, we have a fixed deformity with proximal junctional kyphosis at the cervicothoracic junction, the T3-4 apex. So this focal area of kyphosis, in order to create mobility, should be treated with a 3-column osteotomy, which was our choice, and then connecting the fusion down to that distal construct. You can see here, pre-op, she is placed in Gardner's Wells tongs with biplanar traction. And then the blown up image on the left is just to show you how exaggerated that cervicothoracic kyphosis and then compensatory hyperlordosis of the cervical spine is. So those Gardner-Wells tongs will help get her in position, as well as help after the osteotomy further correct the deformity. So a T4 PSO was done. Like Dr. Ozturk mentioned, because of the degree of the deformity, cervical hardware wasn't placed until after the PSO was done. So thoracic instrumentation was done first. T1, T2 screws placed to get proximal control. The T4 PSO was done, and then once there was mobility in that area of the spine, the Gardner-Wells the traction was used to extend and get her neck in better alignment. Once that was done, cervical instrumentation was placed, and then compression over the rods allowed for complete correction of that area. You can see on the right side her post-op films. Her cervical SVA significantly improved, and then there's a much gentler thoracic curve there, corrected down to 65 degrees, and an improved chin-brow angle. 3 months post-op, seen here doing extremely well, pain relieved, and horizontal gaze is improved. Our next patient, LS, a 50-year-old male who's presenting to us 3 months after an MVC. At the time of the accident, he was diagnosed with bilateral C5-6 facet fractures. He refused surgery that was offered to him, so he was managed conservatively. He's now coming in with neck pain, inability to lift his head, difficulty with horizontal gaze, inability to work. And then of note in his history, he has ankylosing spondylitis and complains of about progressive difficulty standing up straight over the last 20 years. He's full strength on exam, sensations intact. He has limited neck and back range of motion, and then very obvious left head tilt. And then as you can see in the image here, significant kyphotic deformity. When looking at his standing films, it's clear he has two separate issues going on here, one in the cervical spine and one in the thoracolumbar. When focusing on the cervical spine, you see that his C5-6 facet fractures have healed and fused in a fixed subluxed kyphotic position, significantly positive cervical SVA. And then when looking at his thoracolumbar spine, you can see the sequelae of his ankylosing spondylitis. He has flat back syndrome with loss of that lumbar lordosis, a thoracic kyphotic deformity, and significant positive sagittal balance. So in order to correct his deformity completely, he's going to need 2 operations, one on the cervical spine, and then one as well on the lumbar spine. For the cervical spine, again, because it's a fixed deformity, a 3-column osteotomy is necessary to create that mobility. You can see in the bottom picture, this is pre-intubation. Just to get him intubated was extremely difficult because he was stuck in that position. He was placed in halo traction, again, to help position him, and then as well as to use it for correction after the PSO was done. He had a T2 PSO, and then I've noted T-lift cage was used and was placed asymmetric to the left side in order to correct that left head tilt. And then posteriorly, the fusion was done from C2 to T6. After the deformity was corrected, it was noted that the fractures at C5-6 had fish mouth anteriorly. So an anterior approach for C5-6 ACDF was done to give anterior column support. Post-op, you can see here significant correction of that positive cervical SVA and chin-brow angle. So 5 months after recovering very well from his first surgery, brought back to clinic to discuss now his thoracic deformity, the second stage, which you can see in these images here, his left head tilt improved and chin-brow angle as well. These are his uprights, but when looking at them more closely, you see he has 17 centimeters of positive sagittal balance, and then just a severe flat back deformity with 25 degrees of lumbar lordosis, giving him about a 40-degree PILL mismatch. And then looking at his full films, you can see he really has to bend his knees and retrovert his pelvis just to compensate for this still. So because of his ankylosing spondylitis, again, it's a fixed deformity. So the plan is a 3-column osteotomy and done in the lumbar spine to restore that lumbar lordosis, ultimately as the goal of surgery is to try to get him more lordotic there. A pro-axis table for the surgery was used, and initially he was placed in a kyphotic position with chest bolsters just to help position due to his severe kyphotic deformity. These patients with ankylosing spondylitis, although they're fused, even the force of the table can often prove to be too much and can cause fractures. So initially positioning him in line with his kyphotic deformity and then adjusting the table after you create a mobile segment can help better correct that deformity. So for him, an L3 PSO was done with a short rod construct that you can see on the lateral image from L2 to 4. And those screws are buried deep, so that way you can continue the construct above that short segment. At the time of the PSO, the bolsters that were done for positioning were then removed, and you can add that bed manipulation to get him to close that PSO and get more correction. And then ultimately he was connected up to his prior construct to T6. 1 month post-op, significant back pain improvement, gaze and posture improved. He's continuing physical therapy now.
I got a question, maybe, which from the chat room was some folks would say, why don't we do the lumbar first, followed by the cervical spine? Adi, would you just mind to answer this? Why having addressed the cervical spine in this case and not the lumbar spine first? Because we knew and we told the patient we would need to address both.
I think probably the most critical thing is, as I was mentioning, to see and recognize preoperatively that both need to be done is pretty critical. Probably the worst thing you could do is to do a big operation on the patient's neck and patient's still leaning forward, and you say, oh, by the way, now we got to do another one, and that comes out of nowhere. Whereas since we had that conversation, it's much easier. In this patient's specific case anyway, his primary complaint was his neck. So it was the reason he was referred. And we sort of recognized, when we got standing x-rays, we recognized his lumbar, and we said, hey, look, we're gonna fix your neck, but you're probably gonna need your back done down the road also. In the case where and I think we'll actually present this, if there's any neurologic issues, obviously we always start cephalad and work our way down, and that's been sort of our practice. I don't think we've ever done lumbar first, although I don't see a strong reason in the absence of neurologic compromise why that can't be necessarily done. How about you, Dr. Ali? Have you done that before, lumbar first?
I think we have a case where we only did lumbar. Okay, even the problem was a cervical. I think Greg is going to show in this case if we have time. So why don't we just move on to the next case and ask Greg, why don't you just go with your case?
Perfect, sounds good. I'll load everything up.
Just it's the green arrow at the bottom, yeah. Right.
Perfect. Can everybody here and see my slides?
Yes, we
All
can.
right, perfect. So I'm Greg. I'm the other spine fellow over at Penn. Going to be talking to you about a couple of cases. So case one, patient we'll call PA. So this is a 70-year-old female with a history of multiple prior spine surgeries from outside institutions. They were referred to us for a second opinion and evaluation. The patient's chief complaint was loss of horizontal gaze, inability to stand straight, and intractable back pain. Physical examination, no gross motor sensory deficits, 5 out of 5, motor strength, all extremities. Past medical and surgical history, positive for depression, hypertension. The surgical history, she had an extensive prior spine surgery history from an outside institution, notable for PCDF, C2 through 6, as well as multiple thoracolumbar surgeries, which result in the T6 to pelvis construct at the time of presentation to us. Of note, conservative modalities also have not brought significant relief to this patient. So here we go. So standing X-ray, AP and lateral, demonstrating prior T6 to pelvis instrumentation with proximal junctional kyphosis in the cervicothoracic area. You can also note that the patient has prior posterior cervical instrumentation. Preoperative measurements of the chin-brow vertical angle, as well as cervical SVA, demonstrate a CBVA of 22.7 degrees, as well as a positive cervical SVA of 43.7 millimeters. Here we have a preoperative CT of the C-spine with select sagittal cuts, demonstrating the prior C2 to 6 PCDF with the prior instrumentation intact, as well as T2 MRI sagittal cut, which does not demonstrate any significant cervical stenosis or any significant cord signal changes. Here we have a CT and MRI of the thoracic spine, which demonstrate intact instrumentation without evidence of screw loosening. Again, no evidence of cord compression at these levels either. So assessment, cervicothoracic kyphotic deformity causing loss of horizontal gaze with severe thoracic pain secondary to the PJK. So the plan was a PSO, a T5 with extension of cervical to thoracolumbar instrumentation, C2 to T10 with the T5 PSO. This was performed with utilization of the biplanar traction as described previously. So here we have standing lateral images, both pre and post-operatively respectively, status post T5 PSO with C2 to T10 posterior fusion, demonstrating significantly improved horizontal gaze, along with correction of the cervical thoracic kyphosis. Here we have a standing AP pre and post-operative film, status post T5 PSO, where we can better see the inclusion of the previous thoracolumbar construct via utilization of both side-to-side connectors as well as end-to-end connectors. And here we have a comparison of pre and post-operative chin-brow vertical angles. We can see that post-operatively, we have improved her CBVA to essentially neutral at about 0.2 degrees, which is significantly improved from her nearly 23 degrees CBVA preoperatively. And here's another pre and post-operative comparative measurement of the cervical sagittal vertical axis, where the patient has been improved from a CSVA of 43.7 pre-op to approximately 12.1 millimeters post-operatively. We'll save questions until the end. The second case presentation is patient RW. So this is a 66.
Maybe before you go, I have a question in the chat room, which is, what is the long-term quality of life of these patients with a fusion from C2 to pelvis? Adi, you want to weigh in into this?
I think with ankylosing spondylitis, they're quite happy because they were kind of fused anyway. It sort of depends. I mean, I think most of our experience is that when you realign patients, the added rigidity they don't seem to mind, and the loss of motion they don't seem to mind. Most of these patients, when they're kind of referred to us, they've already had a fusion all the way up to the upper thoracic spine, and if they have sort of a severe deformity and you correct that, I haven't had that become a major issue. But it's important, I think, especially with that long of a segment, that being particularly careful that they're aligned well is pretty critical, because I think if they're a little positive or a little negative, it actually has consequence. And I had a patient with a slightly negative balance who they not this one, but a very similar case to that, where C2 down to the pelvis, and he was a little negative. Very happy, but he did tell us that he was sort of falling backwards from time to time, but so I think paying extra attention to a good balance is important. But aside from that,
in the chat room, we have Jens who just stated that the C2 to pelvis do generally very well, but quite well, but need to have full prevention measures and balance training. I agree with you. They're perfectly balanced, Jens. they will do better than before the surgery. Obviously, we don't have any other choice. But definitely fall prevention is important thing, and just balance training. Very good point, Jens. Okay, so why don't you go, Greg, why don't you go with the second case, and we'll take all the question after the second case.
Perfect, sounds good. So case 2 is patient RW. So this is a 66-year-old female with a history of multiple prior spine surgeries done at an outside institution, referred to us for further evaluation, second opinion. Patient's chief complaint, loss of horizontal gaze, inability to stand straight, as well as intractable back pain. On physical exam, patient has no gross motor or sensory deficits, 5 out of 5, all extremities. However, patient requires rolling walker for ambulation now, secondary to reported balance issues. Past medical history was positive for osteoporosis as well as for hypertension. Past surgical history, patient had extensive spine surgery, history from an outside institution, notable for a C4 through 7 ACDF, as well as multiple revision thoracolumbar surgeries, which resulted in the T4 to pelvis construct that we'll see at time of presentation. Again, this time conservative modalities did not bring significant relief to the patient. And this is frozen. Here we go. Sorry about that. So standing erect X-ray images demonstrate loss of horizontal gaze, positive sagittal balance, approximately 13 centimeters, global sagittal balance, extensive posterior thoracolumbar instrumentation, as well as prior anterior cervical fusion noted. So global SVA is about 13 centimeters positive, and the cervical SVA is positive at about 5.1 centimeters. Here we have X-ray, AP, and lateral thoracolumbar spine demonstrating loss of lumbar lordosis as well as bilateral broken rods at the level of L1. Here we obtained a preoperative DEXA scan, which demonstrated the patient had an osteoporosis T-score negative 2.5. Select sagittal MRI CSP and CT cervical, thoracic, and lumbar spine respectively, demonstrating severe cervical stenosis, as well as loss of lumbar lordosis secondary to the iatrogenic flat back deformity. So assessment, loss of horizontal gaze and positive sagittal balance secondary to the iatrogenic flat back deformity. Also, patient is myelopathic and complains of intractable back pain. So the plan was to address the cervical stenosis first, and then perform in a stage fashion the realignment of the lumbar spine with the PSO. The goal of realignment of the lumbar spine via PSO was to correct the horizontal gaze as well as correct sagittal balance. So here's our stage 1, posterior cervical laminectomy infusion. This was by way of a C2 through 7 LAMI with a C2 to T5 PSF. We can see on the image on the right the utilization of 2 side-to-side connectors to the prior instrumentation per rod. Stage 2, this was the realignment and the revision T4 to pelvis with an L4 PSO. And here we have, for further illustration, her preoperative image on the left and postoperative image on the right, demonstrating the changes in her cervical SVA. So preoperatively, we're looking at 51.7 millimeters, which has been corrected to approximately 7.5 millimeters. We can also see the patient's global sagittal alignment has significantly improved from essentially 13 centimeters down to only 13 millimeters. So key takeaway points from the final case here. So we wanted to finish the case presentations with this case as a reminder that we have to ensure that we are being critical of both of our patient examinations as well as our interpretations of the imaging. So this patient was referred to us for her loss of horizontal gaze, which most of us would be thinking down the route of a cervicothoracic etiology. However, when we carefully review the imaging and put it into context with the patient's complaints, we see that addressing the lumbar pathology via the PSO essentially treated both the loss of horizontal gaze as well as her global sagittal malalignment concomitantly. And that's because in this specific case, the root of the patient's problems actually stem from the lumbar pathology masquerading around as a cervicothoracic issue. And we'll open the floor up for some questions.
So anybody has a questions from the chat room? It's me who put this in the chat room. I'd like to get the panelist answer. Do you guys have any input to tease out the imbalance that could be related to cervical myelopathy or severe sagittal imbalance? Easy, you're very clever. Why don't you give us your input on this?
Watch them walk. It's as simple as that. Make them walk down the hall and look at where their legs are in three-dimensional space. Look at what they're leaning on to walk. It's purely physical exam. The sagittal imbalance is very different than a myelopathic gait. So that's what I do. And frequently I get them out in the hall and I say, just walk down the hall, walk back. Let me see what you're doing.
It sounds like we do the same thing, because I just open the door of the cubicle they're in and say, just walk along the hall, okay? And that's the way you sit. But otherwise, the imbalance is there. And it could be either sagittal imbalance or it could be a cervical myelopathy. But it's true, just have them walk is the most important thing to do.
I wonder who trained us.
So in addition to the myelopathy, I do also think that we should be cognizant of myopathies. So a lot of these people have just a general decompensation of the extensor muscles. These are very hard to treat, but to the point of our previous colleague of fusing long, the only chance that you have in these patients is to do a longer fusion, unfortunately, and to retrain them and rehab them right from the start. But I could not agree more than detecting myelopathy first, being cognizant of myopathies, and hedging expectations accordingly, and involving either yourself as a rehab doctor or your rehab team early on is a very big deal in terms of trying to deal with these patients. Thanks for raising that issue, Vincent.
Thank you. Did you have any tricks to assess the myopathy, just to look at the CT scan, the muscle bulk, the MRI? So just you do a clinical exam to see the strength in the back extensor and the hip extension. So what do you have any input for us?
So my main suggestion is to do repeat exams. I find it extremely valuable to do not just repeat exams, but also carefully document them. I'm still writing my clinic notes from the other day, but being very cognizant about that. It's so cool. We have, for instance, neurosurgical colleagues in our clinic, and here's a neurosurgical fellow with us, Abe Schlauderoff. And we frequently go in there as a team or go in sequence, and just everybody kind of looks at the patient individually. But for me, the most important thing is they have to be undressed in their underwear. They have to have their shoes and socks off, and you have to have your reflex hammer and your tuning fork all available. And that's my main thing. And seeing them more than once.
Okay, and back to the old clinic. So any other questions from the floor, just some from the chat room?
I have one more question. The Angst-Bond case was beautifully done, and obviously Paul Kramer was very insightful in asking that question of should we do lumbar first or cervical first. My question is, can you address the question of doing the hip replacements first in these Angst-Bond patients? I have not had to do a number of pretty substantially decompensated patients after I sent them to a hip surgeon, even though they had some cartilage left. They usually have a coxa profunda, and they've done a very nice 3D osteotomy with an open cup placement, and those patients were very happy. They could stand up way better. Didn't correct all of their kyphosis, but can you share some wisdom as to when to do total hip replacements first in AS patients?
I think that's a very good point, because obviously the examination just involved the examination of the hips. And if there's any issue with the hips in the patient with ankylosing spondylitis, to send them to have a bilateral hip replacement is a good thing. Then you have extreme cases like in the cases published in the Japanese or the Asian literature, where you see there was no way to do any positioning of the patient for their lumbar spine or or spine surgery before releasing the hips. So they did hip resection, like a girdle stone first, and then did the spine surgery afterwards to end up with the total hip arthroplasty afterwards. So that's a sequence, a 3-sequence around the hips. But basically, if the patient doesn't have a hip flexion contracture, which may be difficult to assess in a patient with lack of lumbar lordosis and a fixed spine and no pain, I think we have to see where the major issue is coming from, whether it's coming from the spine or from the hips. But your point is very well taken. Never forget the hips. Do you have, I'd like to know in these cases where you have both a cervical pathology and lumbar pathology or thoracolumbar pathology, any room to do both at the same time? I mean, I've been a bit shy from this. And for me, I'm happy when I've done one PSO at one level to get some correction. I'm already happy. I just got away without any problem. So just to go another one would be for me. So anybody would do the to address the cervical spine thoracic. I see Jens who just
we do much less invasive surgeries, you know, in the artificial disc realm, and I've done cervical and lumbar in one surgical setting once, and I have regretted it.
Yeah, I think it's a very wise comment just to stage a surgery.
And even just laminectomies, if someone has tandem severe stenosis, say in the cervical or lumbar spine, I mean, I don't even like doing those on the same setting.
Ali, it's Jackson here. A question about something that you had mentioned in my Rancho Los Amigos days. We would do osteotomies for ankylosing spondylitis without the nice fixations we have now. And one thing that was always a little alarming, even in the lumbar spine, was when you saw the dura become redundant, and you worry a little bit about the roots kinking. But it was much worse in the cervical osteotomies, and I think we used to do them at C7. And you start to see the dura, and then you start to wonder, you know, what the cord is doing inside without the sophisticated monitoring we have now. So, you know, what is your stopgap measure? You know, what is your salvage, or how do you handle that if you start to lose signals as you're extending the cervical spine?
I've never done this without neuromonitoring, thankfully. But if there's a significant reduction in motors, if it's not a complete loss, whether it's this or even sometimes tumor surgery, sometimes just waiting a minute before doing anything, and it can come back. But assuming it's sustained, taking away some of the correction, and another advantage to being able to manipulate the head fairly easily. But it's tricky because we don't want to lose the correction either. So correct it, let it rest, come up slowly. You know, I think to immediately kind of lose all the correction you got is obviously undesirable also. But doing it incrementally and obviously sacrificing some of the correction if that's what it comes down to. It's always unnerving, I think, seeing the dura buckle like that. I never like it, even though I know if I don't see that, then it's probably we haven't gotten any corrections. So
may I ask you 2 points about this? Obviously, it's very unnerving to see that. I think that's where the progressive correction, which is easy to do it with the biplanar traction. You just grab the Garner-Well tongs, the two, and you just position the head the way you want, and then you put one rod and you change the other rod to go back and forth to get more and more correction. So correction is very slow and progressive. The other thing to avoid too much buckling is to put a cage in the front. Once you put the cage in the front, you're going to have you lengthen slightly the end column, so you don't get that much buckling in the back. So I find these two things just relieve a little bit your tension as a surgeon, because obviously we're concerned when we see too much joint buckling.
Hey, Ken.
Hi, Izzy.
Hello, Paul. How are you?
Good evening.
Hello, Paul. How you doing?
Good, Izzy. How are you doing?
I'm well. Thank you for taking the time this evening with us.
Yeah.
A little dry.
Ken, it's Ken, right?
Yep.
Yes, it is. Yes. I literally just got home from Atlanta. It's raining.
Okay,
you
so,
want to
Dog
mute?
here and I was getting.
are we just, I thought we were gonna have a question, okay.
Okay, now we're in the chat. Now we're in the chat room space.
There you
So we've actually morphed into another type
Vincent.
of conference.
Vince and Ollie, thanks again. You guys did great. And never lets us down for great cases. And so we'll see you again
Thanks for
soon.
having us. Thanks for
Thank you,
having us.
Penn.
Thank you
guys.
very much, okay.
Appreciate it.
Good night.
Thank you.
Good
Good
night.
That was a little weird.
Yes, I was wondering which question was gonna come up.
I know. I thought, wait, this is like getting a cross line. Anyway, take care, Vince.
Thank you, take care.
Bye-bye.